Hello, my name is Tobias Welty. I'm the head of the Department of Respiratory Medicine and Infectious Disease at Hanover University in Germany. I want to introduce you into the field of community-acquired pneumonia, the most important infectious disease worldwide in terms of morbidity, mortality, and numbers. There is an increasing incidence for the last 4 decades and mainly in the elderly people. The mortality is low in outpatients, but higher in hospitalized patients. It's highest in patients admitted to the ICU. Looking to the Global Burden of Disease Report 2016, pneumonia is still number 3 in terms of mortality. It has been thought to come down during the last 20 years, but because of the change in demography with more elderly and comorbid patients, it's still where it had been before. The estimated costs of CAP are high, about 1,300 euros reported from Germany to 1,600 from Italy. The detection of the responsible pathogen for community-acquired pneumonia is difficult. All studies demonstrated that even with best workup, microbiologically, only in 1 of 4 patients a pathogen could be found. However, it's quite clear that Streptococcus pneumoniae by far is the most important bug, followed by Staph aureus and some gram-negatives as it is Haemophilus and Klebsiella. Streptococcus pneumonia is the most important pathogen independent from the setting of care. It's the same for outpatients, hospital-admitted patients, and patients admitted to the ICU. There are a number of risk factors which correlate with outcome in community-acquired pneumonia. The most important one is age, followed by comorbidities and the setting of care. It's quite clear that patients from nursing homes or patients from long-term care facilities have a higher risk for complications in CAP. The pathogen does also play a role. Strep pneumonia and Staph aureus have more pathogenicity factors than Haemophilus or Klebsiella and are more likely to have worse outcome. The most important factor, however, is the initial appropriate antibiotic treatment. If this is inadequate, the outcome in terms of mortality and length of hospital stay is worse in comparison to patients with an appropriate initial therapy. Looking to comorbidities, it's clear that chronic heart failure, respiratory disease, diabetes, and malignancy are the 4 most important ones. Resistant pathogens also can occur. This is more likely in patients coming from nursing homes or long-term care facilities and in patients who had been in contact with other ones suffering from multi-drug resistant infection. The most important factor in this circumstance is pre-treatment with antibiotics. As more antibiotics you have seen in between the last 6 months, as higher the likelihood for multi-drug resistant infection is. The REACH study, a retrospective registry performed in 2010 and 2011 and including more than 2,000 patients, underlines that in 3 of 4 patients, comorbidities are present. The comorbidities found here are the same as mentioned before. Heart disease, lung disease, diabetes, and malignancy play the major roles. The REACH study was able to show that these comorbidities are strongly correlated to outcome. Treatment failure, length of hospital stay, and mortality occur much more often with each comorbidity added. This has clear consequences for the future. New antibiotics has to show that either in terms of efficiency and for safety, they are the best in the elderly and in patients with comorbidities. The focus of research has to be in this patient population. Thank you very much for your attention.